So imagine you inherit a patient panel. It's your very first week. You're a brand new psychiatric mental health nurse practitioner, and you're just sitting there staring at the charts.
Oh, yeah. A very familiar, kind of terrifying moment for a lot of new grads.
Right. Because you're looking, and well, three of your new patients are on like 400 milligrams of quetiapine. Two are on 40 milligrams of citalopram.
Wow. Heavy hitters right out of the gate.
Yeah. And then one is taking this methadone mirtazapine combo literally just to get some sleep. So you dig into the files,
Hmm.
looking for a baseline ECG. And there's nothing.
Nothing at all. Blank space.
Exactly. Blank space. You check the intake notes to see if anyone has even asked these patients about like unexplained fainting or palpitations or a family history of sudden cardiac death.
Let me guess. More blank space.
Just totally blank. The risk is sitting right there on the page, completely silent until, suddenly it isn't.
And when that silence breaks, right, when a fatal arrhythmia actually happens out in the community, that blank chart is the very first thing a plaintiff's attorney is going to ask for. I mean, they are actively looking for that exact blind spot.
Which is just a terrifyingly common scenario right now in 2026.
Mm.
But it doesn't have to be your scenario. So today, we're taking a deep dive into the 2026 PMHNP protocol for QTC monitoring.
Yeah, and I'm really glad we're tackling this today.
Me too. Our mission here is to just completely remove the intimidation factor from the cardiology math, and to strip away that sort of arbitrary feeling from all these clinical thresholds.
Because knowledge is really only valuable when you can actually apply it at the bedside. This protocol, it's not some bureaucratic trap that's just designed to slow down your busy clinic days.
Right, it feels like that sometimes, but it's really not.
No, not at all. It's a highly predictable, really effective framework. And honestly, once you understand the physiological why behind the numbers, the ECG stops being a liability.
It becomes a tool, right?
Exactly. A tool that empowers your prescribing rather than making you second-guess it.
Okay, well, let's unpack this. Because before we can fix a problem on the dashboard, we really have to know what the dashboard is actually measuring.
We have to move away from just the theoretical dread of an arrhythmia and get into the hard data.
Right. But first, just as a super quick refresher for the listener, what physically is a QTC interval? Like, what are we looking at?
So the Q to the T on that readout, it's simply the time it takes for the heart's lower chambers, the ventricles, to squeeze out blood. And then they have to chemically reset for the next beat.
Okay, so that chemical reset, that's what we call repolarization, right?
Exactly, repolarization. And if that reset takes too long, the electrical grid of the heart is basically left vulnerable.
Like it's not ready for the next signal.
Right. So the next heartbeat just kind of crashes into the previous one before the system is ready. And that crash, that's the chaotic, twisting rhythm that we call torsades de pointe.
Which brings us to the actual numbers.
Yeah.
The numbers that should, trigger your clinical alarms. There are really only 3 thresholds you need to commit to memory here.
Just 3. It's very manageable.
Yeah. So first, we have what is considered normal, which is anything below 450 milliseconds for men or 460 milliseconds for women. That's your green light.
Yep. Green light, good to go.
Second, you have the borderline zone, which runs up to 500 milliseconds. And third, you have the danger zone, which is 500 milliseconds or above.
And we really need to focus heavily on that 500 millisecond mark because it is not just a clinical suggestion.
That's a hard line, isn't it?
It's an absolute hard line. At 500 milliseconds, the risk of torsades de pointe literally triples compared to baseline.
Wait, it triples just at that specific cutoff?
It triples. That is the threshold where the American Psychiatric Association and, frankly, every major cardiology protocol universally agree. You have to take immediate action, and you need a cardiology consult.
Wow. And, there's also a secondary kind of hidden threshold that catches a lot of clinicians totally off guard.
Yes, the relative jump. This is so important.
Yeah, if a patient's QTC jumps by more than 60 milliseconds from their own baseline, you've also crossed into that immediate action threshold.
Even if their absolute number is still sitting under 500.
Right. So like if a patient starts at a baseline of 410 and then jumps to 480 after you start a medication, that is a massive red flag, even though 480 is technically just borderline.
Because the heart's repolarization is stretching out way too fast, the trajectory itself is what makes it so dangerous.
The electrical reset is failing rapidly.
Exactly, and you have to intervene before it actually hits the breaking point.
But here's where it gets really interesting, though. We have to talk about the ECG machine itself. Because the QTC number that's printed right there at the top of the report, that's a rate-corrected interval.
Right, the machine is doing the math for you in the background.
Yeah. And most machines in the U.S. use something called Bazette's formula. But Bazette's formula is totally notorious for distorting reality.
It really is. It fundamentally struggles with heart rate extremes.
How so? Like, what is it doing wrong?
Well, Bazette's divides the QT interval by the square root of the time between heartbeats. Without, getting totally bogged down in the calculus of it, the main takeaway is this. When the heart beats at a normal resting rate, around 60 beats per minute, the math is basically perfect.
Okay, but patients in a psych clinic are often anxious. They're tachycardic.
And that is exactly the problem. As the heart rate climbs, the formula begins to artificially inflate the QTC number. It overcorrects when the patient is tachycardic, and it actually undercorrects when they're bradycardic.
Oh, I see. So it's basically like a cheap digital thermometer. Like
Right.
if you just drank a hot cup of coffee, it tells you that you have a 102-degree fever.
That is a great analogy.
And if you drink ice water, it says you have hypothermia. It's just too sensitive to the immediate environment.
Exactly. So what does this actually mean for the PMHNP staring at a tachycardic patient with, say, a 460 millisecond reading?
Right. What do you do? Because you don't want to panic.
You absolutely don't panic. It means you do not make a massive clinical pivot based on a mathematical artifact. If your patient's heart rate is outside that normal resting pocket of 60 to 100 beats per minute, Bazette's will distort the picture.
So you shouldn't chase a 460 QTC if their heart is racing at like 110.
Right. When the rate is outside that normal window, you ask the cardiologist for Frederich's correction, the QTCF. It adjusts for those rate extremes far, far more accurately.
Which saves you from abruptly stopping a psychotropic that's actually working just because the patient was, a bit anxious during the ECG.
And we really should ground this discussion in epidemiological reality, too. Torsades de pointes is rare in the outpatient psychiatric population.
Rare but fatal.
Yes. The fatality rate when it does happen is highly meaningful. But the good news is the predictability of who is actually at risk is incredibly high. It doesn't just strike like lightning out of a clear blue sky. It gives you warnings.
Which naturally leads us right into the chemical catalysts. Because if Bazette's formula is falsely tripping our alarms at 460, what should actually be causing a true 500 millisecond spike? Like, let's categorize these psychotropics into risk tiers.
Yeah, understanding these three distinct tiers is really what makes targeted monitoring manageable. So starting with the highest risk tier.
The ones we really need to watch.
Exactly. This includes 5-haloperidol, ziprasidone, especially at higher doses, or taken with a high-calorie meal, which dramatically spikes its absorption.
Right, I remember that about ziprasidone.
And thiordazine, which, you probably won't prescribe newly today, but you will absolutely inherit older patients who have been stable on it for decades.
The high-risk tier also includes some incredibly common daily meds, too, like citalopram. It becomes high risk at doses above 40 milligrams or above just 20 milligrams if the patient is over age 60.
Yeah, that age cutoff is crucial. High-dose citalopram is in there as well, and methadone, particularly when that dose climbs up above 100 milligrams a day.
And the protocol says those specific agents should literally never be started in patients with pre-existing risk factors unless you have a baseline ECG in your hand.
Correct. And any subsequent dose increase warrants a repeat ECG once the drug actually reaches steady state in the bloodstream.
Okay, so then we step down to the moderate risk tier. These are the absolute workhorses of outpatient psych. We're talking quetiapine, paliperidone, tricyclic antidepressants, and olanzapine.
Though with olanzapine, we mostly see the risk in overdose situations. There's also risperidone, which has some mixed data, but it frequently gets grouped right into this moderate tier.
And the crucial detail with this moderate tier is that the risk is highly dose-dependent.
Right, extremely dose-dependent. 50 milligrams of quetiapine for sleep in a healthy 30-year-old is a fundamentally different physiological proposition than, say, 600 milligrams in a 65-year-old who's also taking a diuretic.
Right, which sets us up perfectly for the lowest risk tier. These are basically your clinical saviors.
The ones you want to reach for.
Yeah. Aripiprazole, brexpiprazole, lurasidone, clozapine, sertraline, fluoxetine, mirtazapine, and bupropion.
And aripiprazole in particular produces a near-zero QTC change. It has essentially become the standard 2026 substitute when you need to pull a patient off of ziprasidone.
So when you have a patient who already has this borderline baseline of 465, and you desperately need an antipsychotic that won't nudge that number any higher, those low-risk agents are exactly what you reach for.
Precisely. But, knowing the individual medication tiers isn't quite enough because patients don't just live in a vacuum.
Right, they take other things. We have to address the polypharmacy stacking trap. I mean, the sources we're reviewing cite this brilliant quote from Lindsay Hill at the NP, who points out that patients who get into trouble almost never have just one cause.
No, it's never just one thing.
The QTC gets flagged as a single number on the page, but if you actually dig into the chart, you usually find 3 separate risk factors stacked right on top of each other.
Which is easily the most dangerous reality in psychopharmacology.
But wait, let's look at the math there for a second. If I've got 3 mild QT prolonging meds on a single patient's chart, isn't that just basic addition? Like 10 milliseconds from drug A, plus 10 from drug B, plus 10 from drug C. Why is that an emergency?
That's the trap, because the physiological impact is multiplicative, not additive. The risk compounds exponentially.
Exponentially. How does that work?
To understand why, you have to look at the heart's cellular machinery, specifically the HERG potassium channels. These channels are responsible for letting potassium flow out of the heart cells, which is what creates that electrical reset we talked about earlier.
The repolarization phase.
Yes. So imagine a 67-year-old woman on 40 milligrams of citalopram. The citalopram physically binds to those HERG channels and blocks them. The reset slows down.
Okay, makes sense.
Then she develops hypokalemia because she takes a thiazide diuretic for her blood pressure.
Yeah.
Now, not only are the channels blocked, but there literally isn't enough potassium available to push through the ones that are actually open.
Oh, wow. So it's a double hit.
And then her primary care provider gives her a prescription for ondansetron for some nausea.
Which also blocks the potassium channels.
Exactly. But it alters the channel's gating mechanism in a slightly different way. So these are not just 3 independent little risks floating around doing their own thing.
They're teaming up.
Exactly. The hypokalemia destabilizes the environment, while the citalopram and ondansetron launch this coordinated multi-front blockade on the exact same cellular pathway. They multiply each other's effects. It creates a single highly volatile traffic jam in the heart's electrical grid.
That makes so much sense. And notice how 2 of those 3 medications aren't even psychiatric.
Right.
The cross multiplier that quietly pushes a patient into outpatient torsades is usually non-psychiatric. It's the ondansetron, or the hydroxyzine for itching, fluoroquinolone antibiotics like Cipro or antifungals.
Which is exactly why medication reconciliation is the single highest value safety task for the PMHNP. Catching that PRN sleep aid or that UTI antibiotic from the primary care provider allows you to dismantle the stack before the ECG even has to warn you.
But this raises a really important question about bedside reality, right? Knowing the cellular mechanisms and the math, well, that's excellent theory. But clinical execution is where providers actually stumble.
Right. There are 4 common mistakes PMHNPs consistently make in the clinic regarding this protocol.
Let's walk through them. Mistake number 1 is what the protocol calls the universal baseline trap. Now, I have to admit, as a nervous new grad, my instinct would absolutely be defensive medicine. I want an ECG on literally every single patient before starting any psychotropic, just to cover myself.
Right. Which sounds logical at first, but if we connect this to the bigger picture, blanket defensive medicine completely backfires.
Because it creates a massive data noise problem.
Exactly. Ordering an ECG for every healthy 25-year-old starting sertraline just generates massive clinical noise, it drives up healthcare costs, and it reinforces a totally flawed mental model. If you test a low-prevalence population, any abnormal result you get is highly likely to be a false positive or just a Bezet's artifact.
So who actually gets the baseline then?
The protocol is strictly risk stratified. The patient who needs the baseline ECG is the patient over 60 starting a moderate risk agent, or anyone of any age starting a high-risk agent.
What about the stackers?
Yes, you also test patients with stacking medications, eating disorders that might compromise electrolytes, or a family history of sudden cardiac death. Risk stratification is the true standard of care here.
Okay, mistake number 2 is the absolute number trap. This happens when a PMHNP sees a 460 millisecond reading, totally panics, and abruptly stops the patient's medication.
Which is a catastrophic error. 460 is just borderline. It is not the danger zone.
Right, and abruptly discontinuing a working psychotropic causes immediate, severe psychiatric destabilization.
You risk throwing the patient into withdrawal or psychosis or a depressive relapse. As we established, the action threshold to actually halt a medication is 500 millisecond or a 60 millisecond relative jump.
So at 460, your response should just be careful, dose adjustment, and closer monitoring, not slamming on the clinical brakes.
Exactly. Don't slam the brakes.
Okay, mistake number 3 is the polypharmacy blind spot. You do everything right on day one. You get a clean baseline ECG before starting a high-risk antipsychotic. You pat yourself on the back, the file goes in the drawer.
The drawer closes, case closed. Or so you think.
Right. But 3 months later, the PCP adds ciprofloxacin for a UTI. Or maybe you add a new SSRI because the patient's depression breaks through. The chemical stack just became highly meaningful. But nobody orders a repeat ECG.
And this is a critical failure of professional ownership. The PMHNP who writes that second high-risk agent into the regimen, or who just continues to manage the patient when a dangerous non-psych med is added by someone else, owns the repeat ECG.
You own it. You can't just rely on old data.
You absolutely cannot legally or clinically rely on a 3-month-old baseline when the patient's chemical environment has entirely changed.
And finally, mistake number 4, the documentation gap. A PMHNP reviews a borderline QTC, makes a very thoughtful clinical decision in their head about why the benefits outweigh the risks, and then just types "continue current regimen" into the chart.
Ah, yes. Continue current regimen.
The clinical equivalent of closing your eyes and hoping the check engine light just turns itself off.
It is entirely legally indefensible. If you do not write down what you considered, in the eyes of the law, it simply did not happen.
Period.
Right. Your clinical note must explicitly describe the actual QTC value, the specific risk factors you weighed, the alternative safer agents you considered and rejected, and the monitoring schedule you chose. Documenting your clinical reasoning makes the chart your best defense. A piece of paper with an ECG tracing on it does not protect you.
Your documented thought process protects you. So, what does this all mean when we finally put the theory into practice? We've identified the numbers, the chemical culprits, and the documentation pitfalls. Now we hand you the actual playbook. When that ECG comes back abnormal, what is the exact operational sequence?
The 2026 protocol breaks it down into a remarkably clear action decision tree.
Which is great. So the first action is switch.
Yes, this is your proactive approach. When the QTC is in that borderline zone and you haven't hit the 500 danger mark yet, you swap a high-risk agent for a low-risk one.
Like moving the patient from ziprasidone to or aripiprazole.
Exactly. Or, in a geriatric patient, you transition from high-dose citalopram over to sertraline. You make the strategic move before the alarm bells ever actually ring.
Okay, the second action is reduce and reload. This is for when the QTC is sitting in that 470 to 500 millisecond window. The patient is actually responding beautifully to the psychotropic, so you really don't want to abandon it entirely.
Right, so instead you decrease the dose by 25 to 50%, but the reload part of that step is just as critical.
You have to optimize the serum electrolytes because the heart's electrical gradient entirely relies on them. You need the potassium to be greater than 4.0 and the magnesium greater than 2.0.
Right, think about the heart's electrical system like trying to run a high-voltage appliance on a frayed extension cord.
Ooh, I like that.
When the system is struggling, you don't just dim the appliance by 25% and walk away. You have to fix the wiring.
You reload the potassium and the magnesium so the current can flow safely. You remove any other frayed wires, like avoidable co-prescribed QT prolongers. And then you just check the system again in 1 to 2 weeks with a repeat ECG.
That electrical wiring analogy is the perfect way to visualize it. You optimize the cellular environment so the medication can do its job safely. But then we reach the third action, which is hold and consult.
This is for when the QTC breaches 500 milliseconds or you witness that terrifying 60 millisecond jump from baseline.
Yes, this is where you pause the offending agent immediately and you call cardiology.
But holding doesn't mean stopping it forever, right?
No, and let's add some vital nuance to that consultation step. Holding means hitting pause while a cardiologist helps you stratify the immediate risk. They might clear you to resume at a lower dose, or they might recommend a complete pivot.
But regarding professional ownership, you, the PMHNP, make that cardiology call yourself. Do not delegate that consultation request to a nurse.
A nurse won't have the context to answer the specific psychopharmacology questions the cardiologist is going to ask you. And definitely do not tell the patient to just, go follow up with their cardiologist. You maintain clinical command. You communicate peer-to-peer.
It puts you firmly in the driver's seat. And the decision tree even applies in reverse when you're taking on a brand new patient. Like, if someone walks into your clinic for an intake with a baseline QTC of 480, they aren't unmedicatable.
Not at all. They are simply a patient who should get aripiprazole instead of ziprasidone, get their electrolytes optimized, and get a repeat ECG at steady state.
The protocol just removes all the guesswork. You risk stratify the baseline, monitor the patient at steady state, act decisively at 500 milliseconds or a 60 millisecond jump, and you thoroughly document your reasoning.
It's all laid out for you.
So as we wrap up this deep dive, I really want to give you a concrete piece of homework for your clinic this week. Build a one-page QTC reference card, just one single page. It should have the three thresholds: 450, 470, and 500.
Write down the risk tiers for the meds we covered, too.
Yeah. Put your low-risk substitutes clearly on there, and write down those three action steps: switch, reduce and reload, and hold and consult. Walking into a medication review with that card in your pocket, I mean, it changes everything.
It takes the massive cognitive load right off your memory and puts your focus entirely back on the patient sitting in front of you.
Absolutely.
What's fascinating here is that this entirely shifts how we view the monitoring process. I actually want to leave everyone with a final paradigm shift. What if, instead of viewing QTC monitoring as an annoying administrative hurdle or this looming legal liability, you started viewing the ECG as a holistic metabolic window?
A metabolic window. Oh, I like where this is going.
Think about the reality of modern medicine, right?
Mhm.
Our healthcare system is incredibly fragmented. The cardiologist only sees the heart, the primary care provider only sees the UTI, the gastroenterologist only looks at the nausea.
Everyone is just in their own lane.
Exactly. But when you, the PMHNP, look at that ECG and you catch the polypharmacy stack, the antibiotic from the PCP, the thiazide from the cardiologist, maybe even a hidden eating disorder that is silently crashing their potassium levels, you're seeing the whole picture.
Wow, yeah. By understanding how all these disparate elements affect the HERG channels, the PMHNP is uniquely positioned to be the ultimate safety net for the patient.
You are the one putting all the puzzle pieces together.
It completely reframes the job, because it brings us right back to where we started today. You inherit that terrifying patient panel. You see the heavy doses of Kashipine, the citalopram, the methadone. The risk is sitting there in the dark.
But now it's not silent anymore.
No, it's not. You know how to read the dashboard, you know how to fix the wiring, and you know exactly how to protect your patient.
You have the framework. You are entirely equipped to tackle that panel safely.
Thanks for joining us on this deep dive. You've got this. See you next time.